couple more minutes. And if you guys want to, if you're able to kind of go in another window and get on your social media posts and stuff like that, on my Twitter page, ASRA's Twitter page, ASRA's Facebook, or ASRA's YouTube, although not a huge audience on ASRA's YouTube yet, but you know, you can share out the stream. It should come up there on their respective pages too, just to broaden the potential audience. Hello, everybody that's just joining. We are going to start in just a few minutes. Hey, Nadia, how are you? Thanks for joining us. Okay. Let's get started. Hello and welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA Wrap. I'm your host, Raj Gupta, coming from Nashville, Tennessee. And we are doing a special week this week where we are sort of lamenting the loss of our ASRA spring meeting, but still trying to enjoy each other's company and each other's science. So there are many people that have submitted abstracts for the meeting, and they've been published on the ePosters website. And so we thought we'd take this week every day and kind of go through a few of them and talk about some of the good work that people are doing in the ASRA community. And so we've brought some guests with us to talk about that. But before I get to those guests, I'm going to make a couple of comments. One, we're going to refrain from talking about COVID-19 today. That'll be a nice relief for everybody not to talk about that for at least the next hour. Reminder, these are preliminary research presentations. They are abstracts presented to a meeting. They have not gone through full peer review, so please take all the information as such. Be kind in your commentary. Please join in the commentary, but be kind. This is a place for constructive criticism, but we're not really trying to shame or badger anybody about their work. I am not representing the planning or executive committee of ASRA in the selections of these abstracts. These are purely things that me or the other guests have found interesting, and we thought that it'd be interesting to talk about. We've tried to get some of the authors to present. It's been complicated coordinating all that, so we have a wonderful panel of guests to talk about these topics, which I still think is going to be incredibly interesting. I have no conflicts of interest related to any of these topics presented today. And as I said, if you are an author of one of these posters and you want to put your name down in the comment field, if I've got a minute, I can maybe get you to jump in, but otherwise, we'd love to give you a shout out for it. So without further ado, I'd like to bring in our panel here. Let me get them all on the screen. So Nabil's joining us again from yesterday. Nabil, how are you?
Hey, Raj, how are you? Thank you for having me again.
Yeah, and he got dressed up for me today. No scrubs this time.
Yeah, I got jealous.
And then we got Ed Mariano coming from California. Ed, how are you?
I'm great. Yeah, thanks for having me.
In a very, very busy, occupied office there. Looks like a lot of kids' artwork back there.
Oh yeah, yeah. This is I used to call it my second home, but it's apparently my first home.
Yeah. And then fourth, we have Becky Johnson coming to us from. Is it warm yet in Rochester yet?
Yep. The ice is off the lake.
So it's almost May, right? Almost May, and the ice is almost off the lake. So that's pretty good. We'll take that. So we're going to get started with some of these posters, and I saw somebody trying to join in. If you are an author of one of the posters we're going to talk about today, if you could just put your name in the comments field. When we get to your poster, if I can figure out how to get you in, I would do that, and we'll work on that as we get to those. So let me put the first one up on the screen. Okay, so this is poster number 619. I'm going to put the link in the comments here. Here we go. We've already got people from all over the world joining us today, guys. Oop, I didn't put it in all the... Let me do that again. This gets better as the show gets on. I get faster at this. Okay. So the first one is from Gundersen Health System. Community hospital implementation of the IPAC block reduces opioid use and length of stay after total knee arthroplasty. This is a question that has been bounced around quite a bit. Just to give a gist of this study, if you look at the the methods section down here at the bottom, they've got 80 total patients, 75 that actually went through the study. 38 patients received an after canal block and periarticular injection for total knee plasty. It looks like this was a time-based, like they changed protocols. And then 37 patient canal block with periarticular injection and IPAC block. And the main concept that they're trying to convey in their results here before we get everybody involved is that they did notice here I'm going to try to pull up the data points here. They were looking at morphine equivalents that were consumed. Overall, they saw a general reduction in the patients that got IPAC. The only time that it reached significance was at the 24 to 36 hour time frame. There was a reduction in MMEs for the IPAC group. And then also the overall, if you look at the overall MMEs, it was a reduction in the IPAC group. So, Becky, why don't we start with you? What do you think about this? You guys have been doing all different kinds of management strategies for total knees over at Mayo. So where do you think this new discussion about IPAC block comes in?
Well, Raj, I really like this. In addition, the other abstract that we'll be covering next, and its topic being IPAC, which is incredibly important right now as we try to tease out the ideal techniques for total knee arthroplasty. The Gundersen Lutheran Group is a hospital in La Crosse, Wisconsin, which I would call a very vibrant academic community hospital. I did my intern year there. And the contrast between this abstract and the one we'll cover next provides us an ability to discuss, is there something different about the systems in which we implement regional anesthesia in? And that here we see the use of single injection techniques in addition to periarticular infiltration, and perhaps, and I don't want to spoil our next abstract, might be why there's such a difference in either benefit versus not. Perhaps it's a systems related way to target our techniques.
Yeah, Ed, you want to chime in there? Do you see anything that jumps out at you on this abstract?
I mean, I think that it's important that we get the experiences from community hospitals. I mean, I think as Becky mentions, I mean, this is an academic environment, but at the same time, I think that those of us at university-based medical centers know that so much of our literature is dominated by academic practice when the rest of the world, the majority of our colleagues are not in academic practice. And so I think it is really important to see what people are doing. And I think just as a reminder, I think that we have to acknowledge how many innovations come from community, and IPAC is a great example. And Sanjay Sinha described using this approach as a ultrasound-guided method for anesthesiologists to perform posterior capsule infiltration from his community hospital in Hartford, Connecticut. And this has been now, at least amongst regional anesthesiologists, has been widely accepted as an effective method. So I just want to make sure that we draw attention to that. I think that this and the following abstract, I think, really approach it a couple of different ways. And I think that's important to keep in mind also.
Nabil, before we move on to the next abstract, because it is related, what do you think about the study design? Because there's a lot of places interested in either retrospectively looking at these changes in protocol as a sort of two-tier, two groups, cohorts of patients to look at, one before a time period and one after. I know there's a lot of work that's been done in this study to try to make sure that the groups are equivalent. Do you think that's a fair way to kind of analyze this stuff?
I think it's fair based on the model that you do to make sure the two groups are similar. Whether you just like run your numbers and just see if they are similar or not, or try to do some adjustment to that. So I agree with Ed, like, about the point of the community hospital. The one thing that, like, pertains to the study itself, I don't know if you guys, like, noted, but the decrease in the opioid requirement, it's interesting that we saw that between 24 hours and 36 hours. Actually, I would have expected, like, the decrease in pain scores and opioid requirement to be early on rather than later on. Because if we assume the IPAC block is a single shot injection, why would I expect, like, the opioid requirement to be decreased in the period of time between 24 and 36 hours? By that time, like, in theory, the IPAC block should be gone already. So
I'm just wondering what they're doing at 24 to 36 hours. Is there more motion, more activity?
Exactly.
And their
Thank you.
capsules?
This is exactly what I was trying to get at, because I have noticed, and I don't know what you guys think, like, a lot of, even, like, the work that we have been doing recently, sometimes, like, pain scores and opioid requirement does not go hand in hand. Sometimes there's almost, like, a divorce between the two of them. And at that point, really, I'm starting to develop, like, some belief that the opioid requirement is mainly based on the local culture of each institution, irrespective of the pain scores and the requirement of pain.
I think it's a good time to go to the next abstract because it's kind of related to this concept. Let me pull that up. So for those of you guys following along, this is abstract number 880. And I'm going to put the link in the comments field if you want to go directly to the e-posters. And by the way, ASRA has made these all available to anybody, whether you have a membership or not. I don't know what the time frame is for that, but many of these also have additional multimedia components to them that we're not sharing right now. But if you go to the website, you can see video clips by the authors, some audio clips, some additional pictures or infographics. So I encourage you to go to the website and see what's there. So just as a brief introduction on this one, so this is from UCLA. It's entitled, IPAC block has no additional benefit to patients who receive an adductor canal catheter versus single shot block, and intra-articular injection for total knee arthroplasty. So slight variation. So this is intra-articular injection and adductor catheter versus periarticular injection and single shot adductor block, but the IPAC is the same part. This one had 60 patients were enrolled and they were randomized. So this was at the same time. Half of them got the catheter and intra-articular injection with IPAC and the other half without. And in this, generally speaking, they did not notice any significant difference between the groups in opioid consumption or pain scores. The only thing, and I'll kind of tee off the conversation here, the main thing I saw was that if you look at the morphine equivalents, and I'll zoom in here, the graph that shows the morphine equivalents between the control group and the IPAC group, you see that there's an overall, even though the trend lines are roughly the same, there's an overall compression of the data in the IPAC group. And I'm not sure how to interpret that with this small data set, but just something I found interesting. I'm always curious about variability and predictability of outcomes, not just the absolute outcomes themselves in the mean or the median, but really what's the spread in outcomes. Ed, why don't you kind of piggyback off the previous article on this one?
Sure. I think that it's important to take these two together just because the theme is related, and just to look at and compare and contrast the study designs. So the first study was a retrospective historical control series. Some people would call it a retrospective cohort, or you could do a before and after retrospective design. Yeah, this one is a prospective randomized clinical trial. And I think that that's important because some of the things that, at least one of the advantages of a randomized clinical trial design is that you're prospectively enrolling patients. You have very strict inclusion and exclusion criteria. The idea is to try to have a study population that's as homogeneous as possible, so that way you can try to eliminate some of the known variables. There will always be unknown variables that make the individuals within your sample slightly different, but you try to recognize the known variables that have been shown in the past to create variability, and you eliminate them up front. And so you can take this population now, which I think is important, because to your comment about spread, I think that some of this has a lot to do with just individual variance. And I think if you look at all of the phenotypic and the known genotypic factors that affect acute pain or even persistent pain after surgery, our ability to predict the variance is very poor. So I think what you're seeing there is just the influence of unknown factors that create variance. But I would take this current study that we're looking at right now, the second of the two. This has robust methodology. They do not find a difference with the addition of the IPAC block. You can presume that they've held other aspects of the care and other aspects of the multimodal protocol constant. And I would argue that the negative result here, remember that the negative result in a superiority study, a study that's designed to show that one is better than another, and it's not it is clear to me. So their hypothesis says that they will show a statistically significant decrease. So failure to prove or failure to reject a null hypothesis may mean truly not different, but it also can mean a type 2 error in which you have insufficient data to reject a null hypothesis. So that's also a possibility that this could also be a false negative. And should there have been larger numbers, for example, that maybe there would have been a difference.
Yeah, this is why reviewers harp on the power analysis stuff, because
That's right.
It's for this very reason when you reject the null hypothesis. We just lost Nabil for a second. So, Becky, you want to comment on what you think about the difference between this one and the other one, and how do we interpret IPAC block in the context of this? I mean, again, 2 points of information on preliminary studies, but bring that into context for clinical work.
Sure, and I think Ed stated exactly differences in the study design do play a role here. Differences in the setting as well. Ultimately, when you look at a study, you want to look at whether or not the groups are representative of where your patient population that you would apply it would be in. The difference here is there seems to be an availability at this institution to provide a catheter service. Not all institutions have a vibrant acute pain service and ability to follow up with a catheter. And so looking at what influenced the continuous peripheral nerve block technique that was present in this study and whether or not, based on the numbers, that is dictating some of the results here. Or the mere fact that these patients, because an acute pain service is involved, are being looked at in a different way, additional questions being answered when someone calls to follow up on these blocks. Also, whatever primary outcome that you're looking at becomes important as to delineate away from what other outcomes you're looking at, because therein lies what power you might have to say. Right. I see this team did also look at distance to ambulation and PT, time to PT, which is very important outcomes, but likely not enough study power to provide full information on that between the two different interventions.
Yeah, those are secondary outcomes that may not, even if they had a power analysis, which they didn't report on the abstract, which is understandable, but even if they did, it would have been to the primary outcome. And so seeing no difference can be hard to interpret in those situations. If I've got my tabs right, this third one kind of ties into this as well. So we are moving on to abstract 702, and I'm going to put the link in the comments here. I'm a little bit out of order. So we're staying with knees, but this one is from Duke, and it says the analgesic efficacy of ultrasound-guided genicular nerve block for total knee replacement. And this is a prospective randomized controlled trial. And in this study, what they're doing is they're adding the genicular nerve block into their protocol. And actually, if I remember right, they're doing a sham block as well. So getting to study design, as Ed suggested earlier, not only are you randomizing, but to improve the blinding, even to the patient's point of view, you're putting a sham block in one person versus the other, depending on randomization. These patients all received multimodal analgesia. They got a spinal IPAC block with ropivacaine, and then half the patients got genicular nerve block with Decadron in it, dexamethasone, and half got sham. And then I think post-operatively they received an adductor canal catheter as well with a basal rate, ropivacaine 0.2% with a rate of 8 milliliters an hour. And what their results showed is that they noticed that at 24 and 48 hours that they did notice a reduction in opioid consumption. Nabil, you want to jump in on this one and see where do you think this fits into our more robust understanding of what kind of blocks we need to do around the knee?
Yeah, I think it's like, the idea in of itself is good, and that goes to the concept, especially when it comes to the knee, how low can you go in terms of when you start to blocking. You started from the femoral, went down to the adductor canal block. Now we are at the genicular blocks and the IPAC. So
you forgot the epidural and the lumbar plexus block.
Exactly.
I mean, if you really want to go back, I mean,
yes. Yeah, so we're really getting down to just the nitty-gritty of the terminal nerve supply of the knee. Yeah. Just the one thing, study design and everything, there is nothing wrong with that, but I just sometimes would you wonder what would that add, okay, in light of doing an adductor canal block, meaning in the last study that we discussed, we were looking at the IPAC block in the context of local infiltration, periarticular infiltration. But now we're doing genicular blocks in the context of doing an adductor canal block. So how much addition of analgesia you're adding? It's true that we may be missing some terminal branches of the femoral nerve as they come down and supply the knee, and maybe this is is the target for that. But I cannot tell you that this is going to be widely adopted, because essentially, as Becky said, it depends on the culture of the institution and how much time do you have before each knee arthroplasty, and how much time that you're going to spend doing how many blocks. So if you did that, you're going to be doing a adductor canal block, you're going to be doing genicular nerve block, and you're going to add an IPAC block for a single knee arthroplasty. But in terms of and a spinal, yeah. So, but in terms of study design and everything, I mean, it looks fine to me.
And Becky, are you going to start doing genicular blocks on your knees now too? Adding that into the mix.
I will. I will point out one thing that I found was interesting in the study design. When you look at a sham, would you see how this sham could have potentially included 2 milligrams of dexamethasone, or perhaps systemic delivery of dexamethasone to equal out that exposure? I guess it all depends on what we're looking at it as what we're providing. Is a block to the genicular nerve with an adjuvant local anesthetic and a additive medicine the winner, or could we equalize this out a little bit more?
Yeah, I didn't even pick up on the dexamethasone miss there. Ed, any comments on this one?
Yeah, I mean, I think that you could pick up some very, I think, important study design elements from this particular study. The way that they designed it was really intended to test whether the addition of one more intervention, the genicular nerve blocks, is an improvement over their current practice, which I'm sure it was something that they had considered either because their local IRB suggested it, or because they already anticipated that would be a concern. So so the flow is important. So you notice that they do all of the things that they normally do. They do an IPAC block, they do a spinal. They normally will do their adductor canal catheter after surgery anyway. And then they've just added one intervention, and they use the sham block, which I think that gives you the double-blinded design that you would hopefully desire in your randomized clinical trial. Just as a side note, if you actually blind your statistician to the data, so that way you just have group A, group B, and then you give your statistician the data without disclosing which group, A or B, actually had the active drug, then now you can call that a triple-blinded study or a triple-masked study. And so I don't know if they did that for this particular study because the details aren't in the abstract. But I think if you look at this, there are some potential short-term benefits. I think that the asterisk I would give to that, I think, is something that many of us, actually all four of us, have talked about previously, which is, does that really matter in the long run? And right. and I don't have a good answer to that. I have
this one has 35 milligram equivalents of morphine reduction in the first day post-op. I mean, that's not a small amount. I mean, it's
right,
but
do we know? But I guess what I'm saying is, do we know that 35 milligram or 35 OMEs, does that mean that those patients will have a lower risk of prolonged opioid use later on? Is it going to affect their chronic pain incidence? Is it going to change their long-term functional outcome? And we don't know that. We actually have a manuscript in press for anesthesia that has mapped out the trajectories of pain for different types of surgeries. And for knee arthroplasty, and I'll tell you, the time it takes for patients to go predictably down to what you consider minimal pain is at least a week.
Yeah.
And so I think that if many of the things that we do in the immediate 1 to 3 days after surgery will have some short-term benefit, but if you were actually trying to match your acute pain interventions to the trajectory, they should last a few more days.
Yeah. And I'll just throw out Dr. Mohammed here, who's been kind enough to join us from Israel periodically. Let me get this question up. He says, can we use the genicular nerve block for knee arthroscopies as well? Again, I think that all of it's open to interpretation, but I sometimes wonder, I watch our surgeons do their periarticular injection. I'm pretty sure they probably get the genicular nerves just when they flood 50 cc's of ropivacaine around the knee everywhere. So I'm not sure if our little fine-tuned injection under ultrasound guidance is that much better than their injection in a periarticular injection, or even when the surgeons are injecting around the knee joint for knee arthroscopy. So the intent is good. I think the idea is good. I just don't know how realistic or practical it is. And another question here. Superior lateral genicular is a branch of the nerve to the adductor lateralis, and the previous comment was it's not covered by the adductor. So again, trying to attack any of those remaining nerves that we don't get when we don't do the femoral nerve block, and we're trying to do the adductor canal block. So good conversation about knee arthroplasties. Let's move on to the next poster. So this one's, Ed, I think you'll be happy to see they're trying to adopt that new poster design. We've seen a couple of people do this. It's been nice to see some variation. So this is poster number 933. And let me get the link up here if people want to follow along. Sometimes it's hard to see if you're on a small screen that we're showing you, but so this one is entitled, this is coming from Toronto General, Toronto West, University of Toronto. Low-dose intrathecal morphine is safe for hip and knee arthroplasty in patients with obstructive sleep apnea. So this was a retrospective cohort study, as we talked about study design before, and they looked at patients who were either diagnosed or suspected of OSA based on stop-bang scores. They pulled a sample of 1,326 patients having hip or knee arthroplasty, and about 78.6% of them, of their patients, received intrathecal morphine, which is higher than our normal practice. But and their observation, generally speaking, is that they did not see any significant increase in postoperative pulmonary complications in patients who had OSA and received intrathecal morphine. The way I read the chart is that OSA by itself was an independent risk factor for respiratory complications, but the intrathecal morphine didn't aggravate that risk any more than what they already had. Becky, why don't you start with this one? I don't know if you guys are using intrathecal morphine at all for your joints, but do you have, I mean, the concern obviously that a lot of people have with intrathecal morphine is the respiratory depression, both early and late. And especially when I'm thinking about rapid discharges home for some of these new surgeries, these arthroplasties, I worry about that late respiratory depression.
Right. And this is a study out of a strong group out of Toronto. So I won't go into details about study design as it's a strong study design. I think the clinical question is a relevant one. Myself personally, I'm not using 100 or I'm not using intrathecal narcotic in the tertiary academic centers, but when I go to work in community hospital settings, it is still a valuable method for pain control if you don't have access to other techniques. And what kind of influence that has on your patients that might be more susceptible to respiratory depression, like OSA, I think the clinical question is a good one, and the results are interesting and promising for groups that are utilizing this technique. Although I fully agree with you, this needs to be looked at as to what we're doing with total joint arthroplasty and moving it towards an outpatient procedure in some individuals. And if you're going to use intrathecal opioid in your management, you certainly need to monitor for respiratory complications, which could occur as far as 24 hours out. And so this does limit the utility of this for practices that intend to send their patients home the next day.
Yeah, Ed, thoughts on the use of intrathecal morphine? I know our OB colleagues have kind of are pretty comfortable with giving it pretty routinely for their patient population. Should we be bringing it back to arthroplasties?
Yeah, no, I think that, I mean, I don't think it's really gone away. There are so many different options that we have for regional analgesia for patients having arthroplasty and other surgeries. I agree that our obstetric anesthesia colleagues, I think, have done really the bulk of the research work in this particular field. And I think that there are many factors that go into choosing which technique you apply to a specific surgical population. I think for us, it's similar to what Becky was saying. At our institution, we do not routinely use intrathecal opioids for arthroplasty patients. And some of the decision making is a logistical one. We do have the availability of other modes of regional analgesia. We also have limitations on the number of monitored beds that we can house these patients with intrathecal opioids after surgery. And so I think that those are important factors. I think to Becky's point about the move to shorter and shorter length of stay and outpatient arthroplasty, which is already happening, I think that this is an important consideration. I think that we, as of right now, I think that we generally would recommend postoperative monitoring for patients who have intrathecal morphine despite potential safe pharmacologic profile. But I also think that maybe this is an area for innovation, looking at remote monitoring of patients after they leave the hospital, which is probably something that we as anesthesiologists should probably be looking at as part of our practice anyway, regardless of whether you use intrathecal opioids or not.
And Nabil, I'll let you answer this comment that came in if you want to. Otherwise, I was going to ask you a different question. What intrathecal opioid, and the follow-up to that question was what dose of morphine, if you're using morphine as the intrathecal opioid. Again, I don't know if you use it routinely. I've seen a variety of doses talked about for arthroplasty. The question I was going to ask you was about the monitoring question is, one, do you guys routinely monitor your arthroplasty patients on the floor with continuous monitoring? And two, do you know if your OB colleagues routinely monitor their patients post-delivery who have intrathecal morphine in? Is that a routine thing?
Yeah, so in terms of the dose, I would use a similar dose that's listed in that study, but actually it's not part of our routine practice, like where we do that, we use intrathecal morphine. But I think we are seeing a recurrent theme here in most of the studies. The interpretation of each study has to be done in the context of the clinical environment that it's in. So now I'm not saying that the Canadian health system is different, okay, but maybe it is, okay, in terms of the pressure to get people out. And also, I did not scan the QR code, but I don't know exactly to your point, Raj, like, to the point of your question, I don't know what type of monitoring, like, was available, like, for this patient and what's the protocol. I'll tell you, like, what's happening in our place, that the patient preoperative is going to fall into different strata in terms of risk. And based on this strata, they either go to a normal floor with no monitors, or they go to a normal floor with just a pulse ox, or they go to a normal floor with pulse ox and EKG, or to the ICU. This RST, or the risk stratification tool, is done 1 week ahead of surgery, and it's distributed to all the joints team, both the anesthesia and the surgeon. And each patient, there is one column, okay, that we know where the destination of that patient and where they are going. So this is what we do, and I think it's a good way to be fiscally conservative in terms of using your resources in a wise way. So because if you said that I'm going to monitor everybody, it's very different. We cannot afford to do that. The other thing
also
interesting
the other leg to add to that in the near future, as Ed implied, is a home monitoring answer.
Correct.
That's going to be an interesting kind of leg to add. Sorry,
yes.
I interrupted you. Go ahead.
No, it's okay. OB is very different. When you're talking about a young, healthy female between the age of maybe 18 and 45 years old, it's very different from somebody who is relatively, like, elderly, all right, and they have possible, like, multiple comorbidities, and the risk, like, stratification is very different. So I think we have to consider these two, the difference in patient and the difference in the clinical environment that these cases are done in.
So to answer one of the questions that came in the comments, they're using in their study, if they couldn't read it, is 100 micrograms of intrathecal morphine. I don't know if they labeled which local anesthetic they used for their spinals, but presumably all the patients also got local anesthetic for their spinal. And let me go to the next poster here. You guys doing okay still?
Yeah.
Okay, good.
You're doing a very good job, Raj.
I'm trying. So this is 857 is the poster, and I'm gonna pull the link up here. Okay, so on this one we have, and if you can't tell, we have somebody listening from Nigeria here today. I mentioned Israel. We've got a few different, I think Brazil. So we've got some nice international audience going today. So this one is from Memorial Sloan Kettering Cancer Center. Analysis of a national database for trends in peripheral nerve block usage in outpatient breast cancer procedures. I found this one interesting, and just as a brief synopsis, what they did is they kind of retrospectively looked in the AQI-NACOR, that's the National Anesthesia Clinical Outcomes Registry, from 2010 to 2018, specifically at lumpectomy and mastectomy patients, and tried to see if they received peripheral nerve blocks as part of their management. And they tried to obviously correct for patient variables to see if there was a difference. And it was, I think what was telling was the chart up here, which I'll zoom in on a second. The light blue teal color is mastectomy, and then the orange line is lumpectomy. In the middle of the graph is the year 2014. So you can see a pretty big jump in after 2014, particularly for mastectomy patients, but also for lumpectomy patients. The other interesting finding was something that I couldn't tease out the details of when I was reading this, and maybe you guys can help me, was the region and how, like, where the hospital was in the country, and they've split it up into Northeast, Midwest, South, and West, how that affected the odds of receiving a peripheral nerve block. So, Ed, I want to start with you because, I think you've watched these trends over the last decade and a half, and so you can speak from personal experience from 2010 on. What happened? Why did we get this spike? What do you see happening here? And do you have any insight on the variation they're reporting on regional differences?
Yeah. So thanks, Raj. So I think this is an interesting study for me to read. It's very relevant. So just to give a little bit of context, as Raj had mentioned, the NACOR comes from the AQI, the Anesthesia Quality Institute, which was founded by ASA, and it's considered a qualifying clinical data registry. So anesthesia practices can submit their quality measures through a QCDR database like AQI to CMS for their quality measures as part of the quality payment program. So this is, you could argue, should have fairly robust anesthesia data. And I think that's important because you could argue, well, one of the difficulties with other national databases that people have used in terms of billing registries, may not always capture anesthesia level codes. So arguably, since this is an anesthesia-focused database, you would presume that the data for anesthesia procedures, especially types of blocks, should be relatively true. So there are always a lot of assumptions, but that's sort of the context for the AQI. To your point, I think I've been looking at a lot of these trends for common procedures for a number of years, just because I do think that there are many operations that we do a lot of in the United States. Arthroplasty, as we've already talked about, comes up a lot because we do over 1 million primary low extremity arthroplasties a year. And if you look at the types of the percent of patients who are getting blocks for arthroplasty, which is super common, it's only about 1 in 5 people. Now we're looking at a combination of more invasive and less invasive breast surgery, and I think that the curve itself looks shocking, right? Because you're looking at this steep increase in trend line, but that top bar, if you zoom in on the figure, that the teal line surpasses at about 2016, that's 10%. So yeah, as that curve,
you stole my punchline here.
It's swinging up over 10%. Yeah, but the y-axis is not 100%. I wish it was, but it's not. But we are seeing an increase, and some things that have come up just in the last few years, I think, have been one. Just in the time that I've been practicing anesthesia, we've seen the push for more outpatient surgery versus inpatient stay. And I think that that's been a driver for regional anesthesia. We've seen the adoption of ultrasound, and I think that that has increased the utilization, or at least the ability for us to teach regional anesthesia. We've also seen now, with the last couple of years, the opioid epidemic. We've seen regional anesthesia surge again because of it's always been there, but I think that the attention that it's getting now for being a non-opioid analgesic, I think, is giving it more, I think, its rightful place, I think, as part of multimodal analgesia. And then we've also seen some recommendations, like our European colleagues, the Prospect Group, came out with a paper earlier this year recommending blocks for mastectomy. And paravertebral, they had established as being essentially the gold standard for peripheral nerve block for mastectomy. But if paravertebral was not available, then alternate blocks would also be acceptable for those patients. And I'm currently working through the ASA with the Association of Breast Surgeons to try to come up with pain management guidelines. So we're actually having this conversation right now about, well, what makes sense for this population. And I think that all would agree that if you have nerve blocks available in your practice at your institution, and a patient's having major surgery like mastectomy, then nerve blocks should be offered. I think what we're seeing in lumpectomy and more minor breast surgery is, if nerve blocks are available, then great, but oftentimes they're not available. And so what ends up happening for those patients? And I think what we're seeing is surgeons hopefully are administering local, because I do think that every patient should get a local. The table itself is interesting, and I'm interested to hear what everyone else thinks, but looking at the odds ratios for the region of the country, it's a little bit like shocking. Apparently, if you're having a mastectomy, you should go to the Midwest.
Let me go to Nabil's thought, because I just wasn't sure if I was reading the chart right here. So I'm reading it as the Northeast as being the standard,
It's the control.
The referent. The referent
line. That's the reference, right? So the Midwest, even in 2018, so that's Becky's neck of the woods there. You have a 10 times more likelihood of getting a block for in both in both time frames. In the South, we weren't doing anything before, it looks like, and then now you're almost 5 times higher than the Northeast, and the West is 7 times higher. I have a hard time understanding that data. Yeah. Nabil, any thoughts on that? Because you're up there in the Northeast. What are you guys doing up there?
No, I will tell you. Like, I think you have to understand what is the NICOR and the AQI, and which institutions report to which database. So it's essentially not every institution in this country report the AQI. Actually, if you looked at it, a lot of institutions would not be reporting their data to the AQI. So it's almost like a self-select group. That's why I think you've seen this variability. And quite honestly, I agree with you, Raj. I don't think these numbers. I'm not saying that these numbers are not correct for the database, but I don't think it's reflective of the practice around the country. And this is maybe just a personal opinion, okay? But I don't think this is the truth. Not because of anything that has to do with the Midwest or the South, just because of knowing, the distribution of an institution that report their data to the AQI. The other thing that I wanted to point out, when we seen the increase or the jump in 2014, I think this jump is mainly, again, this is mainly an opinion-related analysis. But I think it's mainly due to the description of the PIC blocks. It was around that time, the big blocks came about. They become very popular. We've seen that in every workshop and every meeting we go to. A lot of people wants to learn how to do them. And then all of a sudden, they offer a good, relatively easy alternative to paravertebral blocks. So all of a sudden that you go from a block that's quote-unquote technically difficult to a block that's technically a lot easier. So it becomes more popular. And that brings the point of easier access to regional anesthesia that Ed was talking about. So I do like that graph because of that. I do also want to point out on that graph, although this is not this is only about 10%, but just you will be shocked also to know that in this country, if you look at something from the CMS database like hip fracture, only about 3% of patients with hip fracture would get any type of blocks, peripheral nerve blocks. So we still have ways to go in terms of providing access to regional anesthesia to a different patient population.
So Becky, unless you have something burning to say about this one, I'm going to move to the next one. Is that okay?
Feel free.
Yeah, I want to get through a couple more of these here. So this one I put up here. I don't want to talk about it for too long just because I like to talk about innovative ideas. This is poster number 960 for those of you following along. I'm going to put the link up here. I love to see people inventing things. That's my kind of cup of tea. And whether it's realistic or not, sometimes that's where ideas come from. This is from University of Texas in Galveston. And it's a novel apparatus and method to identify epidural catheter tip location. So this has been bantered about in various forms, how to identify where your epidural catheter ends up. And this one, they're using a what they call an optoacoustic effect. Basically, they're putting an optical fiber that's thinner than the lumen of the epidural catheter through the epidural catheter till the fiber ends up at the tip of the epidural catheter, and then sending light through that, and then somehow detecting what they call an optoacoustic effect on the external part of the patient's back. And then basically the way I envision how I see this is that it's kind of like finding a stud finder at home where you move it around until you find the peak of the signal. And both up and down and left, right, you can kind of see in the two graphs there how you can find where the maximal point is and identify where the tip of the epidural catheter is. Now, this was done in a simulation, but there is the possibility that it could move to other types of devices in the future. I just found it interesting and fascinating. Is this still a problem, Becky, about epidurals? Do we need to know where they are? Is there a better way to do this? Is this too complicated?
Well, you almost lost me at optoacoustic. So
I just wanted to say that word because it sounds so cool. I think it's my first time ever saying it.
So, as it's never wrong to have another method of either area or nerve localization techniques. Ultrasound guidance has come on the scene as one of the more novel, although not as we continue on, as other techniques from an institution that still values a landmark-based technique to peripheral nerve blockade. It's an interesting look at an ability to find the spaces that we're targeting, but I think it's a long ways off from everyday clinical practice.
So Ed, are you doing some optoacoustics now? What do you think about this? I mean, we go to the meetings, we see all these booths, we see a lot of creative solutions for finding stuff, and the next poster I'm going to put up is also about finding needles. What's your thoughts on this kind of innovation? You think this is a pipe dream?
I mean, I think that I agree with Becky. I think you can't knock innovation. You can't knock the idea of trying to get a better sense of where our catheters go. I think that one of the advantages of ultrasound, at least for needle localization, has been the ability to use portable technology that is not inherently dangerous per se, unlike if fluoroscopy or radiation, to be able to see where our needles are and to check local anesthetic safely around a peripheral nerve or plexus. But right now, we still don't have that type of reliability for catheter placement. And so, and I think that there are some inherent challenges with using ultrasound around the neuraxis, especially as you go below the bony surfaces. So I think that there is a need. I don't know if this would be the one. I mean, I think that we've also heard from some of our own colleagues that have started to incorporate routine fluoroscopy for their thoracic epidural placement. The argument that as thoracic epidural analgesia becomes less and less practiced, that we have to make sure that when they are indicated, that they have to work. So I think that drive to be able to confirm catheter tip placement, I think, is going to be more and more important for us, especially as epidural analgesia may continue to decline in prevalence.
Now, I know Nabil's got to go at 4, but I'm going to get him to chime in on this next poster, and then you can, if you want to put anything about the previous one as well, you can. So this is similar kind of innovation work. So this is poster 646, and I'll put the link up here because I'm out of order here. Another sort of innovation idea. This is from Department of Anesthesia Orthopedic University in Frankfurt, Germany, and Oslo University Hospital in Norway. So a new needle tip tracking system improves needle control of ultrasound-guided lumbar plexus block. This one, actually, they did test eventually on some patients. I think this one they had about 25 patients that were studied using a technique. And I don't think I fully understand what they're doing here. They describe... I'm not going to use the brand name for sake of conflict stuff, but it's a device. It says it has a ultrasonographic needle tip tracking, uses an ultrasound sensor on the needle tip, and then that's translated through software as a green circle on the screen, and allows the user to kind of see where the needle tip is. And then I'll zoom in on the picture here shortly. They show an example of an ultrasound guided lumbar plexus block where you can see the transverse processes, and the needle was placed out of plane technique, and you can see where the needle tip is deep to the transverse processes, presumably to do the lumbar plexus block. They did not, in their 25 patients study, they didn't find a difference in outcomes or in overall time to complete the procedure, but they did notice a reduction in needling hand movements and passes, and how long the distance that the person traveled with their needle during the procedure. Nabil, innovation with this kind, I mean, is this necessary or is this overkill?
No, I think it's great, and I agree with Ed and Becky. You cannot just say that we don't need that, and you cannot be close to any new ideas. So I think we have to be open, we have to embrace them. And at the end, it's like survival for the fittest. If this is something good and something that's going to really change the practice, trust me, it's going to survive. I mean, it doesn't need like, a lot of studies. Like, ultrasound came in like, and over maybe a decade or less, like, it changed the practice. Boom, just like that. So if it is really something beneficial, it's gonna last. And quite honestly, like, a lot of times that may be helpful in something that's out of plane in a deeper block. But just the point is, like, a lot of times you put an ultrasound probe in a patient like this to do a lumbar plexus, and I challenge you if you're able to discern, like, what exactly are you looking at, the structures you're looking at. I mean, if you're telling me that you're gonna do this, like, for a femoral nerve block or for a supraclavicular nerve block, I don't know if it has any utility. If it's something deeper and something that will help us really, I think it's going to be good. So I think it has to be taken for what it is, and if it helps, it definitely something that we have to embrace. Only time will tell.
Ed, you mentioned deeper blocks. I remember when I was training, I routinely would use a 2-inch block needle to do blocks, and I find myself almost never being able to use a 2-inch block needle anymore. So it feels like all of our blocks are getting deeper and deeper, and that may be for a variety of reasons. But Ed, I'm sort of the mentality that I want to keep looking forward instead of always trying to look backwards. And I think that the transition to ultrasound kind of gave us an example of some people looking forward and some people kind of looking in both directions. Should we be looking more forward, more aggressively at stuff like this?
I mean, I think yes. So I think the short answer is yes. I mean, I think to Nabil's point, there are going to be certain blocks like the posterior lumbar plexus that will not be widely practiced. It may not even be widely practiced within centers that used to routinely do it, like ours. This used to be you probably remember this was one of the approaches that we used to use as routine for our total hip arthroplasty patients. To the point where when I was still in San Diego, we did numerous clinical trials of posterior lumbar plexus catheter techniques for patients having the surgery. We don't do this routinely for hip arthroplasty anymore, and we haven't for years because other techniques have come about. Multimodal analgesia has become routine, and there are also so many drawbacks besides the risks. Just some of the expected effects like motor block. And so I do think that as some of these techniques have become less and less practiced, then I think that we will probably need innovations that will help us to do them safer when they are indicated for the right patients.
So I'm going to move on to we only have a couple more here, and I'm going to jump to this one.
Raj,
I know Nabil, you got to cut out.
Yeah, before you proceed, I'd like to thank you, thank Ed, Becky,
sure.
Thank everybody who tuned in. Thank you very much for having me. I apologize, I have to go. So thank you guys. I'll see you tomorrow, Raj.
Bye, Nabil.
Yes, thank you.
Bye.
Nabil's
been
doing a great job coordinating, getting all these shows lined up, so I appreciate it, Nabil. I'll see you tomorrow.
All right, see you tomorrow.
All right, we're going to wrap up with two last ones here, if you guys don't mind bearing with me. So this one, just in the context of innovation still. So this is poster 1033, and it is talking about this catheter over needle system. And for the sake of time, I'm not going to go over the whole poster, but this comes from University of Colorado, and it's called Comparing Nerve Block Speed Using Catheter Over Needle System versus Single Shot Block Needle. And basically what they're trying to say is that if you do a single shot block with a single needle or use this catheter over needle system, the essence is that the amount of increased time that they noticed on their series of 40 patients was about 40 seconds more to complete the catheter over needle system. I don't know if, Becky, have you guys used any of there's a variety of products out there for catheter over needle. Have you tried them? Do you find them easy to use? Does it actually save the time that you compared to catheter through needle systems?
This is where ASRA shines, and going to a ASRA conference is an ideal way to utilize different technologies in a way that you don't feel biased towards a product. So the first time I had my hand over a catheter over the needle system was at an ASRA event. I think the region depends on whether or not you use a through needle technique or an over the needle technique. Here, the group is looking at use compared to single injection for the inner scaling location. And so when I have used a catheter over the needle technique for the inner scaling region, I have found it to be a bit stiffer, maybe even comfort of it being an issue in the inner scaling region, and securement of the catheter, which is a little bit larger bore than your typical through the needle catheter, can be a challenge. And so potentially this savings might be overshadowed in clinical utility.
Yeah, Ed, have you played around with some of these? I think I've talked to you about this before.
Yeah, I have. I mean, I think that the premise of the study, I think, is important, because I think it's looking at the idea of catheter technology and just the concept of extending nerve blocks. And we know that continuous nerve blocks or perineal catheters have a very strong evidence basis to support them for pain control, but we know that not everyone gets them. So they're addressing one aspect, one potential obstacle that keeps anesthesiologists from offering catheters to their patients, which is the time that it takes. Now, I think that may be one aspect, one obstacle. I don't think it's the only obstacle that keeps anesthesiologists from offering catheters to their patients. But I think in their study, they did not find a clinically relevant difference in time for placement. Although I agree with Becky, we've had the same observation with catheter over needle catheters, just because they're stiffer catheters. And so I would argue that I think the time that it takes, the time you save potentially for inserting the catheter, which is very much like a angiocath, compared to the time to secure the catheter, I actually feel like you lose a lot of time in the securement, because I think through the needle catheters, which we're used to using for epidurals, almost come naturally in terms of securement.
Yeah, I think the familiarity. So I think Becky was alluding to this, which is if your standard is single shot block, then this is probably an easy addition compared to converting completely to catheter through needle system, especially if you don't have the sort of motor memory for performing catheter through needle systems. Whereas if you're comfortable with catheter through needle systems, I think that these catheter over needle systems don't seem to add a lot of benefit. And I didn't find that I did them that much faster. Yes, you know, feeding the needle out and the catheter was left there, that part was faster. But, and maybe it was my unfamiliarity, but I found the brand that we used, all the connectors and the dressings, and there's like there's a top layer and a bottom layer, and there's a little origami that goes on. I didn't find it to be very user-friendly, and those will evolve and get better over time. You know, I think the dream is that you stick the needle in, pull the needle out, the catheter stays there, and you slap something on it, and you're done. And I think some places are doing something not far from that. And Becky, to your allusion about the inner scaling, we noticed the stiffness as well. And I talked to somebody, I don't think it was anybody in this group, but it was in Colorado, and they do them all out of plane, sort of like in the approach that you would do a central line, and do the inner scalings that way. So you're sort of feeding it down the sheath, and then that way it's just taped up by the ear, and the stiffness becomes less of a concern in that scenario than if you're coming from the back or at an angle of some sort. So I think that I keep hoping to find one of these that I really love. I personally have not found it, but maybe I'm biased because I'm so comfortable with the other technique.
I think Iman, has a great comment here too, which is just it may make sense for certain sites, but not for other sites. And the example that she gives is tap blocks, and I think that may be a good indication. If for this type of technology. And I think
right.
that there are some, one of the considerations for choosing any equipment is really how readily can you implement it, and then is it something that you can add to your group's practice easily? Is it easy to teach? Is it easy to adopt? Can you apply it as broadly as possible?
Yeah. All right, I'm going to put the last link up here. This is for poster number 636. Becky and Ed, thank you for sticking with me through these. I hate to shortchange all the posters, and that's why I keep putting new ones up here. So this one is from Tulane University in New Orleans. Visual analog pain score at 24 hours using dexamethasone and dexmedetomidine as a perineural adjunct for interscalene brachial plexus block. And this is a retrospective review. Just as a quick summary of what they did, they looked at patients that, again, it's retrospective. They had 105 patients, and they looked at one group that received no additives, one that received dexamethasone, and one that received dexmedetomidine and dexamethasone. And they noticed probably the more significant drop-off in pain scores with the combination of dexmedetomidine and dexamethasone as opposed to dexamethasone by itself. The other chart's a little bit hard to read, but basically there was a higher clump of patients that were on the lower end of pain scores with the combination of both of the additives in there. Ed, I'll send this to you first, is on the question of additives to regional anesthesia. Dexamethasone has been discussed for quite some time. Our friend Chad Bromett talks a lot about dexmedetomidine and feels like that's a really useful adjuvant for peripheral nerve blocks. How do you interpret this, retrospective review, granted, and what other data has informed your kind of decision-making in additives?
Yeah, so I think that, this was a really interesting study to talk about, just because it, similar to the first study that we talked about, it's a retrospective review or retrospective analysis of data in which it's not very clear how the block additives were chosen, and whether this was a practitioner preference or whether there was some change in their practice. I think it's important context to note that the routine care of their patients having shoulder surgery was interscaling catheters. So all of these patients actually had interscaling catheters. The only difference in terms of the plain local anesthetic versus additives had to do with the initial block. But all patients got a continuous perineural infusion afterwards. So I think that that's also important. When we look at the data for additives, in general, there are only a couple of additives that have been shown in very few studies to actually extend the duration of long-acting local anesthetic. So I think that's also important here because they used ropivacaine at 0.5%. And one of those was not included here, which is buprenorphine. Mm-hmm. When you look at dexamethasone, I think there's been a lot of controversy about whether dexamethasone given perinaturally is truly different than dexamethasone given intravenously. And it's only recently, in the last couple of years, that we've seen a couple of studies from Ditran from Montreal that have actually used a systemic control and shown for distal brachial plexus, for axillary and for infraclavicular, that perineural dexamethasone does prolong the block beyond what is the duration for IV dexamethasone. But that hasn't actually been shown with a systemic control for interscaling, to my knowledge. So I do think that the adjuvants are kind of a mixed bag. I think the fact that they're using continuous nerve blocks already, I would argue that to me, I think is really the highest potential level of care in terms of regional analgesia for these patients, because you've given them the titratability. One concern I always have about adjuvants or long-acting, sustained-acting local anesthetics is that that's not a block that you can take away. And so many patients complain about numbness, or in this case, if you happen to have a patient who suffers from respiratory distress because of phrenic nerve block, it's not something that's easy to rescue.
And Becky, are you guys, we typically don't do additives when we do continuous catheters. So I do share Ed's concern about this. The way I read their interpretation is that the initial surgical block has a downtrending period, and the way I perceive their results is that the two additives kind of smooths out that transition from the surgical block into the continuous infusion. I don't know what your guys' practice is, but does this give you some perspective on how you might want to adapt your blocks?
Not necessarily. So again, I wonder if this is just a difference in practice. There is, you know, when you're doing a continuous technique, there tends to be do you load through the needle or do you load through the catheter? And I tend to be a load through the catheter type practitioner. And so in that regard, then, as Ed has stated very well, that you're utilizing the technique that allows you the most continuous type of analgesia, the longest, and with the use of a long-acting local anesthetic, the relative improvement in your additive at that point is very difficult to show. And then, as Ed also mentioned, the systemic control element about whether or not use of multimodal oral and IV use of dexamethasone or dexmedetomidine as part of your multimodal analgesic plan, in addition to your continuous catheters, really that sweet spot. Where I think we have yet to fully vet out in the literature, taking the animal model and applying it to clinical practice, is whether or not some of these neural agents are neural protective. And so at least in animal models, we're seeing potentially where dexmedetomidine does provide some advantage there. But I'm sure we're just waiting for some of these great basic science studies to allow for more clinical translation.
Yeah, I've kind of moved away over the last 5 to 7 years from putting any additives in my blocks, just because I find them so erratic and unpredictable. And again, a lot of this may depend on your local comfort level with continuous nerve infusions. I find those to be something that I can do relatively successfully and control a little bit better. So I tend to shy away, but I completely understand that if you're in an environment where that's not possible, then looking for a way to extend blocks is probably an important consideration. So that winds us up for today. I'm really thankful to you guys for joining. Nabil's been really helpful putting these together and participating. So we'll be back on tomorrow at 3 p.m. Eastern, noon Pacific. Again, tomorrow we're going to be going over some of the medically challenging cases. Nabil's going to be back with us. Nadia Hernandez is going to be back, is going to come and join us. And I think he's got one other person lined up, but we're trying to finalize that. So that should be a great, those medically challenging cases are always interesting, and he's already picked way too many of them to go through in one session. So we'll have to trim those down a little bit, but I think that's going to be incredibly interesting. Thank you, Ed. Thank you, Becky, for joining.
Thank you for having me.
Thanks a lot.
Wish I could see you guys in person this week. Unfortunately, we can't. This is the next best thing. So
what a great idea! I think I'm glad you did this. I mean, thanks for taking the initiative. I mean, I think we can all learn and share. And even though we're missing the chance to see each other in person at ASRA, it just goes to show that we could do this anytime.
Yeah. We could do it all year long.
Thank you so much.
It's a lot of work, though, but maybe not all year long.
Great job, Raj.
Thank you.
Job,
Take care, guys. Stay safe.
Bye.
Bye.